Hello students, I am Aida Aliyeva from Pathophysiology department. We continue our distant lectures. The topic of lecture today is Pathophysiology of nerve system. About etiological factors of nerve pathology. Pathogenic factors that damage the nervous system may be endogenous and exogenous. Exogenous pathogenic factors are divided in two groups, specific and non-specific. Neurotropic factors that damage all the nervous tissue, for example, neurotoxins, drugs that have a neurotropic effect, specific autoantibodies, and others, are called specific pathogenic factors. Non-specific etiological factors damage not only nerve tissue but also other tissues too. Exogenous factors, exogenous pathogenic factors include physical factors, for example, mechanical injury, ionizing rays, oxygen deficiency in the air, and etc. The chemical factors, for example, alcohol, mercury, carbon monoxide, and others. Biological factors, it may be rabies, polio, herpes viruses, leprosy, toxins of the botulism, tetanus, and others. Mental factors, stress, negative emotions, and at last it may be the alimentary factors, for example, starvation, vitamin deficiency. Endogenous factors, endogenous pathogenic factors may be primary and secondary. Primary endogenous factors include hereditary diseases with primary damage to the nerve system, for example, in Down syndrome. Diseases with a hereditary predisposition, for example, the schizophrenia or the Alzheimer's diseases, and circulatory disorders in various parts of the central nervous system. Secondary pathogenic endogenous factors include disorders that occur when organs and systems are damaged as a result of the various other diseases. In this case, the nerve tissue is involved in the pathological process against the background of the development of the underlying disease. For example, hepatic and uremic coma, diabetic neuropathy, and others. Now, the pathology of the nerve cells. Damage to neurons as a result of various pathogenic factors is manifested in the form of disturbance of their functions. These functions include the excitability of neurons, the passage of the impulses along nerve fibers, passage of impulses from one neuron to the another or to the target organs, and exoplasmic transport. Now, the excitability of neurons. The excitability of neurons depends on functional state of membranes of neurons and extracellular and intracellular electrolyte composition. The penetration of sodium ion into the cell causes the neuron to be excited, depolarized. At the same time, potassium and calcium ions play an important role in the formation of the membrane potential. A high concentration of these ions in the environment surrounding neurons lead to the hyperpolarization of the nerve cell, and low concentration or complete absence lead to the depolarization of the neurons. Increasing of the oxidative processes, ATP deficiency, some drugs, for example, luminol, or also the ionizing rays, cold, severe hyperthermia, reduce the excitability of neurons. But mild hyperthermia and slight increase in oxygen content of environment, on contrary, increase the excitability of neurons. The passage of excitation along the nerve fiber is ensured by a sequential repetition of the same process. Penetration of the sodium ions through the membrane of the nerve fibers, then depolarization of this part of nerve fibers, then penetration of the sodium ions through the membrane of neighboring part of the nerve fiber, and the depolarization of the membrane of the neighboring part of the nerve fiber. The insufficient penetration of the sodium ion disrupts the generation of the action potential, and the transmission of the excitation is suspended. Cold, hypoxia, ultraviolet rays, bacterial toxins, for example, diphtheria, typhoid fever, some viruses, influenza, poliomyelitis, cutting the nerve fibers, squeezing of them with scar or tumor tissue, damage of their myelin sheaths, lead to the disturbance of the passage along the nerve fibers. Disturbance of the passage of impulses from one neuron to another neuron or to the working organ of body is associated. Disturbance of synthesis and secretion of neuromédiators, the blockage of receptors binding with neuromédiators in the postsynaptic membrane, and change of activity of enzymes destructing neuromédiators. It is known that impulses are transmitted from one neuron to another neuron or to the working organ through the synapses. The synapse consists of presynaptic membrane, synaptic cleft, and the postsynaptic membrane. Neurotransmitters are synthesized in the body of neurons or nerve endings, transported to the presynaptic region, and are accumulated here in granules. Neurotransmitters are secreted from these granules into the synaptic cleft. These substances connected with the receptors on the postsynaptic membrane ensure the transmission of the nerve impulses. The excitation mediators of the excitation, the synapses, for example, adrenaline, norepinephrine, acetylcholine, then glutamic acid and others, combine with the receptors on the postsynaptic membrane and lead to the penetration of the sodium ions into the cell, resulting in the depolarization. And again, the inhibitory synaptic mediators, for example, glycine, lead to the penetration of the potassium ion from the postsynaptic membrane into the synaptic cleft, which cause hyperpolarization. As a result, excitation occurs in the depolarized cells and inhibition occurs in the hyperpolarized cells. The activity of synapses can be disturbed as a result of impaired synthesis and secretion of the neurotransmitters, blockage of the receptors that bind to neurotransmitters on the postsynaptic membrane, change in the activity of enzymes that break down the neurotransmitters. Due to the fact that synthesis and secretion of neurotransmitters proceeds with energy consumption, a disturbance of these processes is observed in ATP deficiency and commonly during hypoxia. Some toxins disrupt the secretion of the neurotransmitters from the presynaptic membrane in synaptic cleft. For example, the action of the tetanus toxin prevents the release of the glycine, and botulotoxin blocks the release of the acetylcholine into the synaptic cleft. Due to the fact that inhibition doesn't occur in tetanus, tonic convulsions, tetany occur. And in botulism, due to difficulty of the excitation, paresis, paralysis occur. In some cases, impaired secretion of the mediators through the presynaptic membrane may have immune mechanism. For example, in some forms of lung cancer, tumor cells here synthesize the antibody that disrupts the activity of calcium canals. These antibodies blocking the calcium canals in the presynaptic membrane prevent the release of the acetylcholine from the granules into the synaptic cleft. This mechanism forms the basis for the development of Eaton-Lambert syndrome. The causes of disruption of connection of the neurotransmitters with receptors on the postsynaptic membrane include substances that block these receptors. For example, strychnine connecting on the postsynaptic membrane with glycine receptors, or the tubercularine connecting with the cholinergic receptors impedes the passage of the impulses to the postsynaptic membrane receptor. In addition, blockage of the postsynaptic receptors can also occur due to autoantibodies synthesized against them. For example, in myasthenia gravis diseases, during myasthenia gravis, autoantibodies synthesized against acetylcholine receptors on the postsynaptic membrane inhibit the action of the acetylcholine. Now this slide shows us the main manifestation, the main signs of the damaged nerve cell. And there are the pathological lability, pathological parabiosis, pathological dominant, the generator of the pathological enhanced excitation, pathological determinant, pathological system, then the over threshold inhibition, deafferentation, and denervation syndromes. And here I want to explain you in brief about all of them. The first is pathological the lability. The pathological lability first was investigated by Vidensky. He's the Russian scientist, and the maximum number of the action potentials that can be produced by excitable cells within 1 second was taken as a unit of the lability. He gives the first the definition for lability by this way, and this means that the less time is needed to excite the cell and to restore the energy spent on it, the more its lability, and vice versa. Muscle lability is less than nerve fiber lability, and in general, nerve fiber have the highest lability. Lability disorders are manifested in 2 forms: pathological lability and pathological inertness. And in pathological lability, this change in the process of excitation and inhibition are accelerated. At the same time, due to the depletion of the energy reserves, the process is so weakened. But during pathological inertness, the process of the excitation and inhibition at a low speed. They replace each other in the low speed. The next is parabiosis. The special state of the nerve cell between life and death is called parabiosis, and there are 3 stages of the parabiosis are known. The first stage called equalizing stage, and here the strong, it means the high frequently and weak irritations cause approximately the same response. This state is called a mild nerve damage. The second stage called the paradoxical stage. Here the frequently strong irritations of nerve are blocked in the damaged zone, but weak irritations can passage, and as a result there are more responses to weak irritation than to the strong stimuli, strong irritations. That's why it seems the paradoxical. And that's why this stage, the second stage, called paradoxical stage. And at last, the third stage, inhibitory stage, here the no impulses are passage, no impulses transmitted. At this stage, due to the fact that the degree of the nerve damage reaches the maximum level, energy cannot be synthesized in amount necessary to transfer the impulse from the damaged zone. Parabiosis can be maybe the physiological and pathological. Physiological parabiosis is a reversible process, whereas pathological parabiosis is irreversible process, and this leads to the impaired function of the nervous system and even to its destruction. The dominant, what does it mean dominant? The dominant center is a focus of the central nervous system occupying a dominant position at some point. Physiological and pathological dominants are distinguished. Physiological dominance serves for good adaptation of body to changed condition, to the environment, and pathological dominant leads to the disadaptation. The pathological dominant becomes the cause of the prolongation of the course of diseases, to the relapsing of the diseases. For example, prolonged irritation of the central nervous system by impulses coming from area of the nerve damage leads to the dominant pain sensation. It's called pathological sensitive dominant. And about the generation of pathological enhanced excitation. A strong stream of impulses produced by a group of hyperactive neurons may disrupt the central nervous system. And again, the Russian scientist Kryzhanovsky they called such a group of the neurons that generate an uncontrolled flow of the impulses as a generator of the pathological enhanced excitation. What does it mean, pathological determinant? Krzyżanowski says that if the propagation of the impulse stream from this pathological generator is blocked by inhibitory control mechanisms, the function of this generator of pathological enhanced excitement, may be inhibited, may be limited. Otherwise, it becomes the cause of formation of pathological determinant. The pathological determinant plays an important role in the formation and management of the pathological system. An example of the pathological determinant may be strong epileptic focus, combining individual weak epileptic foci in the form of a permanent complex. As such a strong focus determines the nature of the activity of the whole complex as a single system and other foci. By this way, pathological system is formed. Now about the over-threshold inhibition. The inhibition focus, the having overcome normal boundaries, extend to the cerebral cortex and then to the subcortical structures. This condition protects the central nervous system from destructive changes that may occur as a result of the severe irritation. Such process is called protective or overthreshold inhibition. An example of protective inhibition is the torpid phase, the second phase of the shock. And deafferentation syndrome. Deafferentation is the cessation of the arrival of afferent impulses to neurons through the sensory nerves. This syndrome develops as a result of blockage of the receptors on the postsynaptic neurons by toxins, by some drugs. And denervation complex is a complex of change arising during deprivation of innervation of organs and tissues. The denervated structures, for example, muscles, neurons, acquire high sensitivity to the physiologically active substances, to the neurotransmitters. And this is called Kinnon-Rosenbluth law, the rule. And formation increasing of the new acetylcholine receptors are formed in denervated nerve, compensatory along the entire muscle fiber, and the overall sensitivity of muscle fiber to acetylcholine increases. In muscle without innervation, the fibrillar contraction occur. This is due to reaction of denervated muscle fiber to acetylcholine coming from the various source of the organism. The denervation is made by anatomical and chemical ways. In anatomical denervation, the organ and tissue completely lose their innervation, and chemical denervation is achieved through the drugs that reduce the metabolic rate in the metabolic processes in neurons. For example, it may be done by alcohol, by atropine, novocaine, and other drugs. And physical denervation may occur, for example, during the hypothermia. The denervation is manifested by the trophic the disorders, change, motor change, for example, paralysis, hyperkinesis, and sensitive disorders. The basis of motor disorders is damage to motor nerve centers and motorways. Movement disorders associated with the pathology of the nervous system are manifested in the form of the hypokinesis, hyperkinesis, and impaired coordination of the movements. Motor activity is regulated through the pyramidal and extrapyramidal systems. A complete loss of the motor function is called paralysis, and partial loss of this function called paresis. As a result of complete loss of passage of impulses of any one part of the motor pathway, paralysis occur. And as a result of an incomplete loss of the motor nerve ways, paresis occur. Central paralysis and paresis occur as a result of damage to the central motor neuron. In this case, the paralysis is accompanied by an increase in the muscle tone, which is called hypertension. It's called, that's why this type, the central paralysis, called also the spastic paralysis. In central paralysis, voluntary movements disappear and the reflex activity of spinal cord persists. In the damaged limb, tendon reflexes increase, resistance to passive movements increase too, and the appearance of the pathological reflexes is observed. Now you see here the types of the central paralysis, and there are the hemiplegia. It's a unilateral paralysis of lower and upper limbs, and the monoplegia, paralysis of the one limb, and paraplegia, paralysis of the both lower limbs and both upper limbs. And tetraplegia, it's a simultaneously paralysis of all limbs, all extremities, and cross paralysis, paralysis of the upper limb on the one side and lower limb on the other side. And the peripheral paralysis and paresis. Peripheral paralysis and paresis occurs as a result of complete or partial loss of the function of peripheral motor neurons, damage to the cells of the anterior horns and the anterior roots of the spinal cord, or the peripheral motor nerves leads to the loss of the function of the peripheral motor neurons. Peripheral paralysis is characterized by the loss of the voluntary and the reflex movements. As a result of partial or the complete cessation of the arrival of efferent impulses, muscle tone decreases, hypotension or atony occurs. Muscle resistance against passive movement is lost and they become inert. And that's why this type of the paralysis, peripheric paralysis, also called flaccid paralysis. And another characteristic feature of the peripheral paralysis is the muscle atrophy. The volume of the muscle fiber is reduced because of the metabolic disorders in muscle leads to the dystrophy or atrophy. Transverse transection of the spinal cord may completely impair motor functions. This condition is called spinal shock. In spinal shock, blood pressure decreases. In areas below the transection site, excitability decreases sharply, and the reflex activity of the motor centers decreases. Vascular reflexes, urination, and defecation act, all they are impaired. In areas above the transection, changes of innervation are not observed. And when the spinal cord is cut at the level of the fifth cervical segment, the absence of the disturbances in the act of breathing is explained by the fact that the respiratory center and the motor nuclei of the respiratory muscles are located above this segment. And due to the fact that the phrenic nerve, the nerve of diaphragm, lives in the region of the fourth cervical segments, and diaphragmatic breathing continues. In this case, impulses arising the respiratory center located in the medulla oblongata due to the fact that they cannot enter the respiratory muscles, don't participate in the act of breathing. When transected in the area of the transition of the medulla oblongata into the spinal cord, the connection between the working organs and the respiratory and vasomotor centers is broken. As a result, blood pressure drops sharply and breathing stops. If the brainstem is transected between the anterior and posterior quadrupole, decerebral rigidity occurs. At the same time, the tone of the all extensors sharply increases. The upper and lower legs are extended, the muscles on the back of the neck and the back are tensed, and head goes up. The development of the decerebral rigidity is associated with the elimination of the inhibitory impulses from the red nucleus to the spinal cord motor neurons. Hyperkinesis of the pyramidal origin, increased motor activity, is observed in the pathologies of the both central and peripheral neurons. In pathologies of the central neuron, hyperkinesis manifests itself in the form of the seizures, convulsions. Tonic and clonic convulsions are distinguished. Tonic convulsions are characterized by prolonged involuntary muscle contractions, An example of this type of the tonic seizures is prolonged muscle contraction, for example, during tetany. And in clonic convulsions, contractions and relaxation of the individual the muscle groups quickly replace each other. An example is the clonic convulsions of the jaw muscles. During epilepsy, for example, in the hyperglycemic coma, in the hepatic coma, we observe the mixed type of the convulsions, where tonic and clonic convulsions replace each other. Extrapyramidal system controls the coordination and accuracy of the complex movements. If the extrapyramidal system is damaged, its inhibitory and regulatory effects on the motor neurons are eliminated. As a result, impulses coming from the cerebral cortex, the sensory centers, to the spinal cord motor neurons cause uncoordinated, unregulated movement in the muscles. And in the occurrence of the hyperkinesis, the striatum, the cerebral cortex, optic tubercle, the hypothalamus, cerebellum, and spinal cord are involved. The following types of the hyperkinesis of the extrapyramidal origin are distinguished. The first, for example, athetosis. Athetosis, this is slow tonic movements, mainly in the muscles of the legs, extremities, and sometimes in the muscle of the face. Then the small chorea, the random, fast, irregular the movements of the muscle of the limbs, face, or body. The torsion dystonia. They are the slow, tonic, mainly circular movements in the cervical and lumbar part of the body. Then hemiballism, it's a large movements of limbs, so mainly the large movements hands, similar as the movements when throwing the ball. Tremor, they are the involuntary, rhythmic, regular trembling of the head. Lower jaw, the tongue, the trunk, limbs, or the distal parts of the body. Then it may be observed the spasm during writing, spasm of the fingers, which is observed only during writing, and hemispasm of the face. They are the periodical, repeated tonic and clonic contractions of the muscle of the single half of the face, and sometimes it may observe the blepharospasm. Blepharospasm, it's a spasm in the circular muscle of the eye. Often it occurs the bilateral. And you see here in this slide the muscular rigidity in the hands or catalepsy. These disorders, these manifestations refer to hypokinesis of the extrapyramidal system, and hypokinesis of the extrapyramidal origin manifested in the form of the muscle rigidity, catalepsy, you see here. Prolonged preservation of the position attached to the trunk or limb. In the contrary to the central paralysis and paresis, pathological reflexes here are not observed during extrapyramidal hypokinesis. Distortion of the coordination of the movements. Coordination of the movements is regulated by various parts of the central nervous system. They are cerebellum, brainstem, optic tubercle, labyrinth, and posterior horns of the spinal cord. Damage to these areas leads to the disturbance of the coordination of movements, and this is called ataxia. Cerebellar, cerebral, spinal, and vestibular type of ataxia are distinguished. And in cerebellar ataxia, there are some characteristic symptoms are observed. For example, aesthesia, loss of the muscle ability to contract effectively. Then asthenia, the fast muscle fatigue. This occurs due to uneconomical energy consumption as a result of aesthesia. And dysmetria. The patient cannot reach out to the desired distance, cannot reach out to the object to take it. This is called hypometry or hypermetry. And dysarthria, the disorder of speech, the slow, extended syllabic speech. This is called dysarthria. And megalography, the patient handwriting becomes uneven and the letters are very large. Then nystagmus. What does it mean? The rhythmic movements of eyeballs of large amplitude, the vertical and horizontal nystagmus are observed. In the cerebral ataxia, this is associated with the damage to the frontal and temporal lobe of the brain. And unlike cerebellar ataxia, in the cerebral ataxia, the patient falls to the side of opposite of the injury damage. And on the side of injury, muscle tone increases. The third is the spinal ataxia, occurs as a result of damage to posterior columns of the spinal cord. In this type of the ataxia, the patient cannot control the movements of the lower extremities in the rhombic position. Rhombic position means standing on the legs with closed eyes. In this position, the patient falls back, which is called rhombic syndrome. In vestibular ataxia, it's next form of the ataxia, the patient falls to the side of damage, and here the nystagmus is observed also. Pathological reflexes mean reflex reactions that lead to the damage to the nervous system and limit the body's adaptability to the environment. There are various types of the pathological reflexes: perverted reflexes, pathological reflex contractures, reflex paralysis, unusually projected reflexes. The basis of the perverted reflexes is the appearance of dominant foci in the nervous system. For example, in the presence of a dominant focus, the excitation of their motor neurons increases, which lead to the increased activity of the dominant focus of the excitation in the extensor neurons. As a result of this, its extension is observed. The pathological reflex contractures occur during the formation of the dominant foci of the excitation in the spinal cord. Impulses transmitted from the inflamed joint to the spinal cord form here a focus of dominant excitement. And as a result of the contraction of the flexor muscles, this leads to the severe pain sensation. And the pain further enhances the dominance of the focus of the excitation. All the result in the formation of the vicious circle, and this causes limitation of the movement in this joint, and this is called contraction. The reflex paralysis occur as a result of inhibition of the activity of the motor neurons by impulses from the sensory nerves. And unusually projected reflexes arise during elimination of the inhibitory effect of the higher part of nervous system on the spinal cord motor neurons. An example of the unusually projected reflexes is Babinski reflex. And the Babinski reflex is the normal due to 6 months of the baby, but in old ages is the abnormal reflex. It's a pathology of the central nervous system, and Babinski reflex characteristic for the central paralysis. Now about the disturbances of the sensitivity. Loss of all types of sensitivity is called anesthesia, and loss of only pain sensitivity called analgesia, decreasing of the sensitivity called hypoesthesia, increasing of the sensitivity called hyperesthesia, and perverted sensitivity called paresthesia. In case of damage of the peripheral nerves, the first sensitive neuron, all kinds of sensitivity in the area of its innervation are lost. If the pathological process is located at the level of the second neuron, then in this case there is a loss of the certain types of sensitivity, and this condition is called dissociation of the sensitivity. And changes occur during transection of the anterior and posterior columns of the right or left half part of the spinal cord are manifested in the form of Brown-Sequard syndrome. You see here the main manifestation of the Brown-Sequard syndrome. In this case, paralysis occurs on the damaged side, and tactile and proprioceptive sensitivity are lost. And on the opposite side, temperature and pain sensitivity are lost. This is due to the intersection of the pathways of the pain and temperature sensitivity in the spinal cord. Because tactile and proprioceptive sensory pathways, as well as pyramidal pathway, don't overlap in the spinal cord, loss of these types of sensation, as well as the motor disorders, occur on the side of the lesion. If the spinal cord is completely cut, then all kinds of sensitivity are lost below the cut on both sides. Pain is an unfavorable sensory and emotional feeling that occurs as a result of mechanical, thermal, chemical, and other factors. The classification of pain is based on the number of the principles, and according to the clinical features, acute and chronic, local and diffuse pain are distinguished. Pain is divided into physiological and pathological types. Physiological pain is protective in nature. It signals about the damage and aims at its elimination. Unlike this, pathological pain occurs against the big background of damage to the particular parts of the nervous system. According to the development mechanism, somatic visceral pains are distinguished. Somatic pains are superficial and maybe deep. Somatic superficial pains are these pains felt on the skin. And the next slide will demonstrate the differentiation of these types of the pains. Now the table demonstrates the differentiation of the early and late pain. Early pains occur immediately after acute damage, and their localization is easily determined. Late pain occur in a certain time after damage and are debilitating, widespread, and continue for a long time after cessation of the pathogenic factor. Somatic deep pain include headache, the toothache, muscle pain, joint pain, and others. Somatic deep pains are often prolonged and don't have exact the localization, and they are accompanied by general weakness and vegetative reactions, for example, nausea, the sweating. Visceral pain occurs in the internal organs. It's accompanied by general weakness, reflex contraction of the skeletal muscles. Depending on the duration, the pain can be acute and chronic. Acute pain disappears quickly after cessation of the factor causing it, and chronic pain is severe, prolonged, debilitating, and painful for the patient. And the following types of chronic pain are distinguished. For example, neuralgia. Neuralgia is a pain syndrome that occurs in impaired peripheral nerve function. For example, trigeminal neuralgia is manifested by more acute pain. Causalgia. Causalgia is severe pain arising from the damage to large somatic nerves, and it's accompanied by severe sweating, some vasomotor changes. Phantom pain occurs after amputation of the extremities, in a missing limb, in a missing extremity, in a missing the leg, for example. A feeling of the pain, severe pain occurs. Thalamic pain is a spontaneous pain that develops during damage to the nuclei of the thalamus. Our body has some mechanism which protect, which limit the pain, and these mechanisms called anti-nociceptive system. The anti-nociceptive system ensures natural mechanisms that limit the pain, and neurophysiological and neurochemical anti-nociceptive mechanisms are distinguished. The neurophysiological mechanisms are associated with a specific group of neurons, and as a result of their stimulation, the activity of afferent systems that transmit nociceptive information to the higher parts of the brain weakens or completely stops. What's about neurochemical mechanisms that are associated with the analgesic effects of the neuromodulators? And there are four the anti-nociceptive system associated with the interaction of the neurophysiological and neurochemical mechanisms you see here. For example, the opiate analgesic system, for example, the member of this system, enkephalin, the hormonal opiate analgesic system, for example, beta endorphin, and non-opiate analgesic system. There are some the neuromediators, for example, serotonergic, noradrenergic, dopaminergic the systems and others, and hormonal non-opiate analgesic systems. These include vasopressin. Disorders of vegetative or autonomic nervous system. We know the vegetative nervous system consists of the parasympathetic and sympathetic departments, and the activity of the autonomic nervous system or vegetative nervous system is controlled by higher centers they located in the hypothalamus. The activity of the hypothalamus is carried out under the control of the cerebral cortex, and most organs have both sympathetic and parasympathetic innervation. Sympathetic and parasympathetic nerves have an antagonist effect on the organ functions. For example, the irritation of the sympathetic nerves accelerate heart work, and irritation of the parasympathetic nerve inhibit cardiac activity. The sympathetic nerves inhibit the activity of digestive system, whereas the parasympathetic nerves straighten it. And for investigation of the functions of the sympathetic and parasympathetic systems, some experiments done on the animals. For example, desympathization. Desympathization means transection of the sympathetic nerves, and some the manifestation signs that appear in this the case. For example, you see here this desympathization, lack of the sympathetic innervation, follows by this change. The motor function of the stomach and intestine increase after desympathization, occurs spasm of smooth muscles of the old sphincter and bladder. Then the hypoglycemia, neutrophilia, lymphopenia, all they observed in blood during desympathization, because the sympathetic nerve system acts by this way in the metabolism, and body temperature decreases. And what about the vagotomy? Vagotomy means the transection of the vagus, the parasympathetic nerve, and these signs, the symptoms occur during vagotomy. The parasympathetic innervation disturbance, the secreting of the gastric and pancreatic juice are reduced. The breathing becomes deep and rare. Here we observe delay of the Herring-Brier reflex, and bronchi and pupils expand. This is called mydriasis. Heart rate increase, and because of the loss of parasympathetic innervation, and intestinal motility decreases. Neurosis. Neurosis is a disorder of the higher nervous activity. The higher part of the central nervous system includes the cerebral cortex and subcortical structures. The cerebral cortex is the highest organ that regulates and coordinates all processes in the body and forms the basis of the thinking and consciousness. Here the analysis and synthesis of the stimuli take place, and the body is adapted to the external environment. Neurosis is a functional disorder of higher nervous activity, and this is based on the disturbance of balance between excitation and inhibition in the cerebral cortex, and also disturbance of the first and second signaling system. In contrast to the mental psychical illness during neurosis, degradation of the person doesn't occur, and person is aware of his illness. There are three forms of the etiological factors in the development of neurosis: biological, social, and psychic. Biological factors include hereditary predisposition, gender, more common in women, and age, puberty, and menopause. In these periods of life, it may occur pregnancy, and etc. The social factors, it's maybe unsuccessful marital the status, the unsatisfactory living condition, working condition, and others. The psychic factors, maybe psychological traumas suffered in the childhood, situation of the depression, severe illness or loss of the loved ones, difficulties at work or at school, and etc. And it's believed that the main etiological factor of neurosis is mental trauma, and other factors create the condition for the development of the neurosis. And you see here three main classical clinical forms of neurosis are the neurasthenia, hysteria, and obsessive states. The most common form of neurosis is neurasthenia. It's a weakness, depletion of the nerve. The etiological factor of disease is a long mismatch between the real capability and desire of the person, individual, increased self-demands. Neurasthenia is characterized by increased excitability and rapid depletion of the nervous system. The main symptom complex of disease is asthenia. The headache, dizziness, heart pain, loss of the appetite are observed during neurosis. And persons with neurasthenia exaggerate their diseases, often undergo the various medical examinations. Hysteria is more common among women. The main feature of this disease is functional impairment of the movements and sensitivity, emotional disturbances, and the patient is easily subjected to self-hypnosis. Patients, on the one hand, turn to doctors for treatment, and on the other hand, don't want to leave their this disease condition. And the clinical signs of disease include hysterical convulsions, hysterical disorders of the autonomic vegetative nerve system and motor functions, hysterical mental disorders. And the third is obsessive states, manifest themselves in the forms of phobias, fears. And according to the content, phobias may be associated with a particular life event. For example, nosophobia is fear to get sick, the serious illness. The psychophobia, fear to get the mental illness. For example, it observed acrophobia, it fear of the heights. Agoraphobia, fear of crossing the wide streets. Monophobia, fear of the loneliness. And oncophobia is the fear of the cancer. Besides the functional change in the central nervous system, for example, as during neurosis, there may be organic change, organic damage of the higher nervous activity. And in contrast to neurosis, in this type of diseases, higher nervous activity undergoes more deeper change, and the mental disorders occur. This includes Alzheimer's disease, Parkinson's disease, and others. The clinical signs of Alzheimer's disease appear gradually over 10-15 years, and memory is lost, which is called amnesia, and behavior and intelligence change, thinking slows down. Along with amnestic dementia, apraxia, and agnosia are detected in these type of diseases. And the main pathogenetic mechanism we will show in the next slide. Alzheimer's disease is a neurodegenerative disease of the central nervous system. This is a disease with hereditary predisposition. The basis of this disease is the accumulation of the beta amyloid in the cells of the central nervous system, and mainly in the cerebral cortex. Amyloid is formed as a result of disturbed cleavage, disturbed breakdown of the transmembrane protein, which called the APP, amyloid precursor protein. APP, amyloid precursor protein, normally breaks down with the participation of three enzymes. There are alpha, beta, and gamma secretases. If the mutation in one of these genes encoding APP, this protein, and these enzymes, then its cleavage, this big breakdown is disturbed. and beta amyloid gradually accumulates in these nerves, in the nerves of the cerebral cortex, and this gradually leads to the neurodegenerative disorders in the neurons of the central nervous system, and to the death of these nerves. And in brief about Parkinson's diseases, it's another type of neurodegenerative disease. And the basis of the Parkinson's disease is a partial insufficiency of the dopaminergic system of the brain. While the black substance is damaged, dopamine synthesis is impaired. Normally, dopamine reduces the activity of neurons in the caudate nuclei, and caudate nuclei in turn inhibits and restricts motor function. And when black substance is damaged, dopamine synthesis decreases, as a result of which the activity of neurons in the caudate nuclei increases. And the following are the main signs. The following signs of the Parkinson's disease appear. The first is hypokinesia, is limited movement, loss of the facial expressions, masked face is called, small steps, lack of natural hand movements during walking. The next is muscle rigidity, muscle hypertonicity, manifested by the resistance against the passive movements. Then tremor, the main sign of the Parkinson's disease is involuntary trembling of the hands and lower jaw. And in Parkinson's disease gradually develops dementia and motor impairment. This is due to the progression of the neurodegenerative change in the cells of the cerebral cortex. Thank you. Thanks a lot.